would like to request you all not to get panic. Do the 5. Practice social distancing. Follow hand hygiene. Follow respiratory hygiene. Avoid touching your face. Keep a distance of minimum 1 meter with others. Know the symptoms of COVID-19 infection. Use personal protective equipment when required. And most importantly, follow recommendations of Government of India, WHO and FOGSI, and stay safe, stay healthy and stay at home.
అందరూ ఆరోగ్యంగా ఉండండి, జాగ్రత్తగా ఉండండి, మీ ఇంట్లోనే ఉండండి, కరోనాని తరిమి కొట్టండి.
स्वस्थ रहे, सुरक्षित रहे and please घर में रहे.
स्वस्थ रहे, सुरक्षित रहे और घर में रहे.
ಆರೋಗ್ಯವಾಗಿರಿ, ಸುರಕ್ಷಿತವಾಗಿರಿ, ದಯವಿಟ್ಟು ಮನೆಯಲ್ಲಿ ಇರಿ.
ஆரோக்கியமா இருங்க, பத்திரமா இருங்க, அவரவர் இல்லங்களிலேயே தனிமையா இருங்க.
নিজকি হুষ্ঠা আৰু সুৰক্ষিত কৰি ৰাখিবলৈ ঘৰত থাকো.
स्वस्थ रहो, अपने अपने घरा में बढ़ा रहो, बाहर मत निकलियो और अपनी अपनी सेहत का ध्यान रखना, सुरक्षित रहो.
Stay healthy, stay safe and just stay at home.
निरोगी रहा, सुरक्षित रहा आणि फक्त घरीच राहा.
सुरक्षित रहो, स्वस्थ रहो અને ઘરે રહો.
स्वस्थ रहो, सुरक्षित रहो और घर में ही रहो.
স্বাস্থ্যকর থাকুন, নিরাপদ থাকুন এবং কেবল ঘরেই থাকুন.
सुरक्षित रहंतु, फिट रहंतु, घरे रहंतु.
घर रबती, सुरक्षित रबती आणि फिट रहा.
सुरक्षित रहे, स्वस्थ रहे और अपने घर में रहे.
घरी रहा, सुरक्षित रहा, गर्दी टाळा, आरोग्य जपा.
The health and well-being of people have always been a priority at Bayer. In the present pandemic situation, we acknowledge and appreciate the relentless efforts of medical fraternity to deal with this health crisis. Stay safe, stay healthy.
Today, as most of us are trying to be socially responsible and staying at home, the doctors and the medical staff are playing the most crucial role of being out there in the front line in dealing with the COVID-19 situation. Bayer salutes their commitment for rising up to the occasion and going beyond the call of duty. Stay safe, stay healthy.
So very good afternoon, ladies and gentlemen. Very warm welcome to this webinar on PCOS. So we have more than 1,000 delegates who have registered as of now for this webinar. So on behalf of Bayer, I would like to welcome each one of you, all the elite panelists and the audience as well. So even though we welcome you, but before that, we would like to thank you to all the doctors, all the support staff, for this extraordinary role which you are actually making us more comfortable so that we are able to say that yes, I am fine because you are at the front line. So thanks a lot. Thank you so much once again from our side. So with this, I will just take you through a couple of slides, maybe just another 4-5 minutes about Bayer, what we do. So our purpose as an organization is Science for Better Life. Why I say so is because like Bayer is not only into pharmaceuticals, not only taking care of human lives, but also crop lives as well as animal life. So we also collaborate very strongly to with WHO, UNO, and all global agencies for maintaining the sustainable goals. Because food security, health security, these are very, very crucial part of our society. As far as women's healthcare business is concerned, we are a global leaders, and we in India basically kind of have initiated this Bayer for Women, which not only talks about our heritage as an organization, not only talks about our innovation. Since 1928, Bayer was into the research and development, especially in the women's healthcare arena. We have our quality brands available in the country, and we thank you and thanks the fraternity for having trust in our quality and for our brands. Best workplace for women, yes, it has happened. We have been nominated here in India, not once but twice. And also we run a lot of women-centric social responsibility. So I'm not going into the details, but this would speak volumes as where our commitment to the women of the society. And just to taking it forward with changing times and technology getting advanced. So we have also initiated few patient initiatives, and we are trying to support the patient with a lot of credible information, the right kind of information, along with the digital tools. What I'm just kind of introducing it you as one application what we have, Bear Your Pain. This is barely for endometriosis, which actually empowers women who is suffering from endometriosis to understand the symptoms, journey, and diagnosis. So similar to this, we have one chatbot. So we have introduced this chatbot, and we could inaugurate this and launch this during our FOGSI meeting in the month of Jan. So this is on contraception. We appreciate and respect that contraception in our society and culture being a very private topic, and the women can have a one-to-one chat, and this chatbot basically kind of directs you to the physician. So we were lucky to have Dr. Nozer also as a part of our press briefing and launch of this chatbot in Lucknow this year. So as far as today's topic, PCOS, and as we mentioned earlier also, we being the pioneers in women's healthcare arena. So, so we were the innovators of cyproterone acetate, also our brand name being Dime 35. So we do a lot of activities in the field of PCOS. We have kind of introduced around more than 1,500 clinics across tier 1, tier 2 cities and metro cities. Like we call it as PCOS clinic, where the doctors are empowered with a lot of educational material, patient awareness material, a lot of collaterals, so that a patient would come and get encouraged to ask about the symptoms. And also we have tied up with the retail stores. We have tied up with the diagnostic laboratories, so that there is a full value chain which is being offered to the patient. Something non-medical also. So we had this walkathon a couple of years back in 4-5 major cities, including Mumbai, Bangalore, Ahmedabad. So had a good response. This was just to create awareness in our own small way. So with your appreciation and positive feedback, probably we'll continue doing this. So we have a lot of PCOS awareness talks being organized, and speakers being among the fraternity in schools, colleges, and corporates, which again is a small step, baby step towards spreading the awareness on PCOS. As we understand, the incidence of PCOS increases day by day. We have a lot of international experts coming and sharing diets with you. So we have a lot of international speaker programs all across the country to update the audience and update the fraternity about the latest in the field of PCOS. So last year, under Madam Dr. Nandita Palshetkar's presidentship, so this was a very unique and innovative way, because nothing and not every time you talk something new on any disease therapy or any therapy basically. So we thought, okay, like we should have something new which is very handy and effective to the practitioners. So we came out with protocols for practice. So this pioneering PCOS initiative, it kicked off with a pan-India meeting in Mumbai. You can see Madam Nandita unveiling the collaterals and the outputs. And the outputs were in the place of PCOS patient counseling guide, a tracker, checklist, patient risk calculator, and obviously patient booklet. So this was an attempt which was done for the first time by us, involving more than 50-60 gynecologists all across the country. So we had 3-4 meetings across the country, along with a centralized meeting which I spoke about in Bombay. So just a glimpse of the collaterals and the outputs what came out of this meeting. So before I introduce Dr. Rakhi Singh, so you all know, so we have this high-powered, esteemed panelists all joined us, and I would especially welcome Dr. Malvika Kohli, because I think we are meeting for the first time, that too virtually. balance, at least gynecologists, we keep on meeting at various forums. And of course, so ma'am, welcome to this forum, and hopefully we'll have a long time collaboration and association in future as well. So before I leave the stage to Dr. Rakhi Singh, just introduction. Everybody knows Dr. Rakhi Singh. Dr. Rakhi Singh has been the chairperson. Can I have that slide, Simon? Yes, it's there now. Yeah, I'm able to see. Yeah. So she has taken this initiative as the chairperson of Endocrinology Committee of FOGSI for this year. So this webinar is basically the output of that. Dr. Rakhi Singh is the current secretary of UP State ISAR, Infertility Society, and she has been organizing chairperson and secretary for many congresses. And she's also director of Abalone Clinic and IVF Center, Noida. And of course, she's a senior consultant and fertility specialist. So with this, I hand over it to you, ma'am, to take the proceedings further. And a very warm welcome once again, and thank you so much from Bayer. Thanks a lot.
Thank you, Mr. Deepak from the Bayer viewers. And good afternoon, all my fellow FOGSians and all my friends and seniors. It's always a pleasure to invite one of the wonderful TOG for the wonderful TOG webinar, which has been conducted by the Bayer and Science Integra team in hand. And I take this opportunity to invite our power-packed panel for the PCOS advocacy, clearing skin, creating confidence. I would like my panelist. We've got Dr. Nozar, sir. He is the secretary. He was the Secretary General of FOGSI, and he's the past president of MOGS, and he's working with Breach Candy Hospital and Hinduja Hospital. He's a member and technical advisor of WHO. He's got many books to his credit, and he is a wonderful person. If you ask a knowledge about any subject, he's thorough with it. He will have ABC in line always. And we've got the Dr. Sonia Malik. She is also another pioneer. We've got all the pioneers over here, all the pillars. And she is the past president of Indian Fertility Society, and chairperson. She has been the chairperson of Infertility Committee, and she is the past president of Indian Menopausal Society and the director and head of the department for the South End Fertility and IVF Center. And she has been a member of ICMR, a task force on genital tuberculosis. We all know her with her robust work, what she's done for genital tuberculosis. Dr. Nandita Palshetkar. Who doesn't love talking about her? She's the past president of FOGSI, and she's just handed over. And at present, she's the president at MOGS from 2020 to 2022. And she's the chairperson of MSR from 2016 to 17, past president for IAGE 2017, member of National Guidelines for Accreditation, Supervision and Regulation of ART Clinics of India. And she's been director for 9 of the IVF Bloom centers in India. The lovely Dr. Nandita, ma'am. And we've got bubbly Dr. Seema Pandey. She's always full with energy and the academics. She's the director of Seema Fertility and Eva Fertility Clinic. She's president of Azamgarh OB-GYN Society, secretary of UP State of ISPAT chapter, and national executive member of the ISAR of India. And she's got books written on PCOD, and she's co-editor for the Handbook of Infertility and FOGSI Focus also. We've got Dr. Sebanti. She's a chairperson of Quiz Committee of FOGSI. She's an associate professor at Kolkata Medical College, and special interest in vaginal surgeries and cosmetogynecology. Dr. Sebanti. We've got Dr. Malvika Kohli. She is the aesthetic dermatologist with us, and she's going to give us all the tips and tricks about PCOD in relation to the aesthetics. and the director of Skin Seeds, Dermatology and Aesthetic Center at Mumbai. And she is a consultant to Lakme India Fashion Week, Femina Miss India Contest, and Cosmetology Society consultant she is. I welcome my all power-packed panelists to this PCOS advocacy, clearing skin, creating confidence in all the adolescents and the young children. Can we have the cases, please? We've got our first case over here, and she's a 17-year-old obese amenorrheic. Weight gain she's been having for past 8 years, since 8 years of age. Menarche is since the age of 13 years. Later developed secondary amenorrhea. Family history, normal weight. The parents were hypertensive, hypercholesterolemia, and impaired glucose intolerance. Glucose tolerance was there. Mother was gestational diabetes during pregnancy. Physical examination, the child had BMI of 29, waist circumference was 25, and BP was normal. She was hirsute, and facial acne was seen. Oily skin in the nasolabial folds and forehead was seen. No acanthus nigricans was there. Lab test, what revealed were the free testosterone levels were normal, the LH levels were normal, FSH, estradiol, and 17-hydroxyprogesterone was normal, whereas elevated free testosterone and LH levels were there to tell that she's a PCO, I'm sorry. Normal serum thyroid, prolactin, and 24 hours free urinary cortisol, normal blood glucose, abnormal lipid profile, elevated total cholesterol, LDL, and triglycerides. My first question is to Dr. Seema Pandey. How do you want to diagnose this patient and how do you want to go about? What is your diagnosis at the first appearance when the patient comes?
Yes, Rakhi. Looking at the history, we've got everything. I'm looking at the age of this girl. For all the information I have got, she's definitely going to be a case of polycystic ovarian syndrome. But since looking at her year of menarche, that was 13 years, and she just crossed 4 years. So if we follow the international guideline, we'll keep this girl as high index of suspicion for developing full-blown PCOS. And at that moment, we are just treating her as a case of hyperandrogenemia who's going to be, and she's just at the borderline of age. For all practical purposes, she is having full-blown polycystic ovarian syndrome.
Right, Dr. Seema. Dr. Nozer, I wanted to understand what are the lifestyle modifications you want to suggest this patient, this girl, and what would be the best treatment approach for this adolescent girl?
Right. As Seema has rightly said, let's face it, PCOS is a diagnosis, but PCOS is a spectrum. And the spectrum can be either from a woman who's completely normal and functional, going all the way to complete disruption. This young girl has a lot of disruption. She's amenorrheic, and secondary amenorrhea obviously is something they're concerned about. We've got obesity. The first line treatment for a patient like this would be lifestyle modification. First line drug treatment for a patient like this would be hormonal, and maybe we'll discuss that a little later. Now, we know for sure that PCOS can be two different types. You can have the obese, which probably are 2/3, and you can have the lean PCOS, which are approximately 1/3. And the advantage of the obese PCOS have is that in their case, bringing down their weight and bringing them to a relatively more normal BMI will give dramatic improvements in many of their clinical symptoms. Now, lifestyle modification is overall, it's holistic. It starts off with obviously a healthy diet. And we know today that we are facing an epidemic of obesity in young girls. Secondly, this usually needs help. It's all very well for us to tell them in our clinics that, eat right and turning the mothers on them. But unless you've got that girl motivated and with you, it's not going to work. So you've got to bring in a professional dietitian who can help with this girl's diet and help her get a diet that she's willing to follow for a length of time. Exercise. Now, exercise is something that's different for different people. Finally, it has to be aerobic exercise because she's got to burn calories, since she's got to balance the inflow and the outflow of calories in her body. And it's something that she may want. I mean, you need to speak to her and understand. For some, it may be walking, jogging, swimming. Like I tell my patients, you need something to pump up your heart, because that's when you start burning calories. It could be Zumba, it could be dancing. Find what that girl wants to do, and I promise you that girl will then do it, be satisfied, and go much further. As far as the diagnosis of the case is concerned, I think the first thing a girl like this would require is a progesterone withdrawal. Get her to have a period with medroxyprogesterone acetate, 10 milligrams twice a day for 5 days. And that's when you have an opportunity of doing all your hormonal investigations and deciding the way forward. I think I'll leave this for now because we've got other panelists who might also want to talk about the hormonal management of this patient.
Rightly said, Noza sir. And actually the diet platter for this patient ideally should have all the colors, not being focused towards one color in the plate when we are having food. And one meal a day at least should be with the whole family. When they are sitting together and eating, that will also help many a times for these adolescent kids. But at times it is difficult in that today's running around situations also.
Raki, you're dealing with an adolescent. You're dealing with an adolescent with a mind of her own.
Yes.
And unless we understand this adolescent's mind and you become her champion, you become her advocate, you become her co-conspirator. If she feels that you are siding with the mother, you've lost her. Unless you get her on your side, it's not going to work. And I like your idea of a plate. If you have a plate of half vegetables, half carbs, and half a quarter carbs and quarter proteins, that's the kind of meal which is considered to be the meal this girl probably requires. But obviously, you need to also give young people what they like and what they want.
How many of us eat that, yeah?
I would like to ask Dr. Sonia Malik, which age would you consider if you are giving OCPs for this patient?
Well, presently she's 17 years old. So basically we are looking at her when she's quite old. But I suppose you want to ask me how soon can you start OCPs? Had she been younger? Had she been presented to us, say, at 13 years when she first became irregular periods? Would we have started her on OCPs? So basically, like Dr. Nauzia just now pointed out, we in India are very conventional and we would not want to start our patients so soon on OCPs unless it is really warranted and unless we feel that they are actually not going to stick to our dietary regimes and the exercise or whatever, and they are pained about irregular periods. That is the time, we can. But the reports which are coming from other countries have an added problem of teenage pregnancy at hand as well. And some of our own teenagers are also facing that. So for the contraceptive problem, we could start them as early as 10 is what is reported across the literature. However, in India, and coming back to this PCO, generally what is said is that adolescent PCO is diagnosed only if there is an irregularity of period for more than 2 years. So if she is presenting with an irregular period for the first time, there is no need to put her on OCPs. But yes, if she's had a consistently irregular period or she's remained amenorrheic for a long time, you could put her on small doses of OCPs in the beginning as well. That is not something that is not reported or that is not done. But like I said, in India, the mother is going to get after you. And as Dr. Nozer said, you have to have the daughter as well as the mother on your side. You can't just have the teenager on your side. You have to have the mother as well, because she's the one who's getting the teenager to you, and she doesn't want her child to be on hormones that early. So you have to balance what you're giving to the patient, and the best thing, of course, as he said, would be to give her a progesterone challenge and to keep on giving her periods. maybe every 3 months, so that the periods are, she gets a period every 3 to 4 months, which should be good for us. But she may not be put on oral contraceptives, the conventional one, at early age of 13. But yes, 17, yes. At this age, yes, it is indicated because she's not only, she's having features where she might go on to even metabolic syndrome. We are looking at her, and she's got, her BMI is high, and she's obese, and she's got hyperandrogenemia. So it's basically to correct all that we are giving it, not just that we are fancying that she is, getting. And then we all have to remember that this age group is very, very conscious of her looks. So the self-esteem part of it is also very important for us to address. And we all know that when you're giving them hormones, there's a very good feel-good factor, because the acne disappears and the hirsutism becomes better. They start feeling normal. So therefore, we have to look at that aspect of this teenager and prescribe her OCPs.
Which OCPs would you prefer, the cyproton acetate or the drosperinone ones, or which ones do you want for
the
this?
Skin problems. Yeah, Seema wants to say something before that.
Sorry, ma'am. Sorry for interrupting. Just for the answer of this question, as 2018 PCOS Society Guidelines of India, they have stated if you have to start the OC pill for a girl, that should not be below 14 years of age.
Yes,
14
yes.
years
That's right. 15 is what is internationally quoted, but yes, if the PCOS Society of India says 14, it could be 14 for India. But we also mustn't forget that in India we have a very high incidence of we have a very high incidence of hyper homocystinemia, and therefore the thromboembolic phenomena is something that we must be very careful about in our own population of young girls. So that is definitely there. Coming back to, sorry.
Dr. Nozar wanted to tell something.
Yeah. So firstly, I agree and I disagree, because our treatment has to be individualized.
Yes,
we have girls today reaching menarche at 10. You're not going to let them suffer symptoms for 5 years because a guideline told you to wait till 15. Once she's well into adolescence, once she's achieved the growth potential, and now she has symptoms, we can't wait for the lifestyle modification to take care of her symptoms. We need something to deal with her cycles. We need something to help her cosmetically. And we know that the first line treatment is going to be a combined oral hormonal contraceptive.
Yes.
Now, in this particular situation, just to quickly answer the question you asked, the best thing we have as Indian gynecologists today is choice. You decide what you want to use depending upon her problem. If my girl's problem is primarily menstrual, then cyclical progesterone could be good enough for her. You could use micronized progesterone. You could use medroxyprogesterone from day 16 to day 25. Clockwork cycle, everyone is happy. You could do it for as long as you want. If she also has cosmetic issues, I would start with the OC with cyproterone acetate. But here I must tell you, and this is personal, I am not happy to give a 35 microgram OC pill for a very long time. So once I've got my initial benefit with the cosmetics within 3 months or 6 months, I would prefer to move on to a drosperinone containing OC pill. I would then move on to a 30 microgram drosperinone OC pill. And after 3 months, she's doing very well. I will drop it down to a 20 microgram drosperinone OC pill, which she can now take without interruption for as long as she needs, which means even for years. In this particular situation, if she lands up with the breakthrough bleed with the 20 microgram OC pill, then of course I can always go back to the 30 microgram OC pill. So in this particular situation, I think we've got to individualize case by case basis. I completely agree with what my co-panelists have said. But if we were to only try and put our patients into guidelines, let's face it, we read the guidelines, they don't. They do whatever they're going to do, and we've got to adjust our treatment to them.
Guideline, the word guideline means it's just there to guide. It doesn't mean that we have to use it for every
Absolutely.
patient.
I agree, Sonia.
No, but you know what? Everybody follows it. So we have to be really
of course.
of what we put in it.
That's true. That's true.
coming on to this, if we are going to put the patient on OCPs, in Indian scenario, many a times the parents are not willing to take the OCPs for their kids at this early age, and they will tell no for it. And how do we counsel for it? I would like Dr. Nandita to answer. And how long can we give these patients?
I think Indra has put it so beautifully that oral contraceptive pills is something that this girl needs. What I normally do when I'm sitting in the clinic is I talk to the girl and the mother. I have to tell them that there is a stigma associated with OC pills. You know, when you keep it in the house, anybody, if you're in a joint family, they'll say, oh, the girl is taking oral contraceptive pills. Is she sexually active? But that is the fear in their mind. So when you tell them that supposing you have diabetes, you have to take insulin because it's a problem. And if you don't take it, you will have other issues. So that is how I explain to the couples, to the mother who comes with a child, that there is a problem in your child. The problem will be solved by behavioral therapy, weight loss, etc. But in the meanwhile, please take these pills because they'll help you. And I think the one with the cyproterone acetate is a beautiful pill to start with because she starts glowing and she looks good and she feels so good about herself. So I would continue the pills for 6 to 9 months normally, then tell her to take a break because it's very difficult for somebody to take 21 pills all the time. So 6 months, 9 months, or even a year is what I would give these pills, and then switch over, stop for some time, just give her a break of a little while and then switch her over to a continuous very low dose pill. That is my protocol. And there are studies, I think that something was, there was a 2018 study, which I remember, that they gave the pills for 5 years and it's absolutely fine. So I think we shouldn't worry about the pills per se. Counseling is very, very important to the girl and to the mother.
Yes, there are studies reporting that we can give it for continuously for 5 years with a break of every pill packet. I think Dr. Nozar, sir, yeah.
Yeah. Sorry, I think Sonia also had a finger up. I'll go after Sonia.
No, I just wanted to make a comment on this beginning, starting the pill. There are studies which are indicating that the earlier you start the pill, the incidence of breast cancer there was a longitudinal study, and 4 years, if you started at 10, then it is 4 years in advance. If you started at 12, it is 3 years in advance as compared to the other population. So we do have to keep that also in mind. I understand that we are getting our girls are getting menarche at earlier age, but then our younger girls are also getting breast cancer at a younger age. We have to keep that in mind. Just remembered it. It's just that I remembered the study.
Dr. Nozar.
So firstly, let's not call it an oral contraceptive pill.
Of course it isn't.
Let's call it a combined hormonal pill.
Yeah.
I tell the patient's mother that this is something we are now using more for contraception than for contraception, and more than half its use is now for the non-contraceptive purposes. I will also reassure them and tell them it's perfectly safe, and I too will continue it for many, many years as long as I feel that it's required. And if you keep meeting them from time to time and talking to them, they are fine. My concern again with cyproterone, Nandita, is my experience, weight gain is an issue with the cyproterone pill, which we don't find with the drospirenone pill. And of course, if there is a mild cosmetic problem, I might just start with the drospirenone in the first place, and I might not even go to cyproterone. And finally, find an excuse to be doing an abdominal examination or whatever for the girl, and behind the curtain, when the mother's not around, just whisper to her and ask her if she is sexually active. And if she is, she has to take the pill. But then behind the curtain, I'll also tell her that she has to also protect herself with a condom, because dual protection is important. And I will also tell her, for God's sake, don't tell the boy that you're using the pill, because then he'll refuse to use the condom.
Great. That is another add-on advantage of it for the young adolescents. And I think Dr. Sebanti has been quiet for quite a long time. She is a cosmogynecologist with us. And I would like to know, the patient is again having facial acne and she is very much concerned about it. I wanted her to highlight on the pills what she wants to give and how does she want to manage her oily skin. Dr. Sebanti.
Mike.
Dr.
Am I audible?
Yeah.
So, no doubt, after seeing the picture of the girl which you showed in the first slide, we know that she is having hyperandrogenism. There's no doubt about this. And as she was having a lot of Hirschsprungs and she was having acne. And you are asking me about acne. Now, to tackle this hyperandrogenism, and at the same time, to tackle also the irregularity of the cycle, the combined hormonal contraceptives definitely will come into the scene. And the question is, why are we using this for hyperandrogenism? Because we know that they are having a combination of estrogen and progesterone. And definitely this progesterone is going to, inhibit the LH and is going to reduce the amount of the androgen produced by the theca cells. Whereas the estrogen is going to increase the level of SHBG, that is a sex hormone binding globulin, and definitely the amount of the free testosterone, which is more in the Hirschsprung woman, is going to come down. So while choosing a combination of this estrogen and progesterone for this girl who is having acne or Hirschsprungs, that is overt signs of hyperandrogenism, we would definitely choose that progesterone. Estrogen is that same one, but the progesterone is the one which is to be taken care of. Definitely, we have to choose that progesterone which is having anti-androgenic activity. So here comes the role of drospirenone first. And if we want to add a direct anti-androgen with the estrogen, that is the ethinyl estradiol, then there the role of cyproterone acetate comes in. So we have pills which are combination of cyproterone acetate and ethinyl estradiol, and we have pills combining drospirenone as well as ethinyl estradiol. But cyproterone acetate will be a more direct anti-androgen because it's an androgen receptor antagonist, and that's going to inhibit the action of the the dihydroxy testosterone, which is the direct one on the hair follicles and on the pilosebaceous unit. While she's having acne, the fact is that the hyperandrogenism is basically causing increased sebum secretion from the pilosebaceous units. And that is where we want to put it at a check. And so that is why the combination of a cyproterone with an ethynyl estradiol will be the better one in controlling the acne in this case. And secondly, you asked me how she is going to keep her skin less oily, isn't it, Rakhi?
Yeah.
Now, there are certain non-pharmacological measures also which the dermatologists will help more. They're asked to wash their skin repeatedly, but that doesn't mean taking the entire oil out of your skin, because that the more little of oil you have on your skin, you look younger for a more time, definitely. Along with that, certain topical agents can be helped out by, I think Malvika can help us in telling about those topical agents too, which would help in the skin. But from our point of view, the combination oral contraceptives, or as we say CHCs, would be better. And an addition of a direct anti-androgen in this case, like a spironolactone, has been tried in many cases, but the ones like flutamide and finasteride, they are also there. But we do not usually prescribe it to the adolescent girl in the initial years so quickly. They're more meant for the men. And whenever we give it for a woman, we definitely have to give the OC protection along with that. Because if a woman, not for this girl, because if a woman with PCOS is also in the childbearing age group, putting her only on anti-androgen just for acne and Hirschsprung won't do. Because if she falls pregnant, then anti-androgen is going to severely affect the sexual development of the male fetus.
I would like Dr. Malvika to come over here and just highlight upon the same, her viewpoint on that acne and then this oily skin, what she wants to give for that. Dr. Malvika.
Mike.
Unmute yourself.
Unmute your mic.
Yeah.
I'm unmuted, yeah. Thank you very much for having me on this panel, very prestigious panelists. And I've been very keenly listening to all of you because I think we work hand in glove when it comes to such cases as you're discussing. I'm in agreement with almost everything that's been said. As far as I'm concerned, in this case, there are a few things I would like to know in addition as somebody who's going to be working with the oil gland and the hair follicle. That's where I come in. So the first thing I'd like to know is what were her fasting insulin levels. Second, I'd like to know her dihydrotestosterone levels, DHT. And I'd also like to be a little wary with drugs in her because she already has an elevated lipid profile. So drugs like oral isotretinoin, flutamide, finasteride, I would have to be very careful about giving them in case she is already prone to metabolic syndrome as well as eventually maybe a fatty liver. So when I'm treating a patient with acne, such as the case, you can see it's predominantly along the chin and the jawline, and this is typically a distribution of inflammatory hormonal acne. Here there is a lot of inflammation, a lot of bacteria, and there are also a lot of comedones. These are very deep comedones. So if you try to treat them with rubbing and scrubbing and facials, it's going to create havoc. So we need to actually take a step back, and we usually in these patients give either a mild 1 to 2% salicylic acid face wash or a 1 to 2% glycolic acid face wash. We also do appreciate today that acne-prone skin is also sensitive. It also has less water in it. It's dehydrated, though it doesn't look so. So sometimes we give lactic acid or lactobionic acid face washes. We give this twice or thrice a day, not more. Avoid rubbing, avoid scrubbing. We then treat such a patient first with a good course of oral antibiotics, linocycline, doxycycline, minocycline. These are our preferred ones. We can also use azithromycin, clarithromycin in very severe cases. But the tetracycline group, of which linocycline has come into huge focus nowadays. And we'd first probably give a 2 to 4 week minimum course of oral antibiotics, topical such as benzoyl peroxide, clindamycin, the topical retinoids, to start clearing up the acne. We do not over dry the skin because then the topical actives will cause even more dryness. Once the inflammation has come down, then we can look at low dose oral isotretinoin to start with and build it up gradually. But during this time, this also helps to tide over the phase when you have given cyproterone or you've given drosperinone, because they take at least 1 to 2 cycles to work on the skin. Once this active inflammation comes down, we also help it along with a set of peels. We can also do peels such as salicylic and azelaic acid peels, low strength glycolic acid peels, which will help to ameliorate the acne because these girls are severely affected by it. They keep putting makeup, which makes worse, and anyway, makeup doesn't hide it. So this is how we would progress then and allow your drugs to work, and then bring in our next step, which would be oral isotretinoin, or maybe not. If she improves, maybe not. What's also trending is to use dapsone gel now. That is also very good anti-inflammatory for us. Now we come to the next step, and that is your question about laser hair reduction. But this was our approach, this would be our approach. And we usually do peels once every 2 to 3 weeks. About 4 are enough. And then we tell them to do peels every 2 months or every 3 months if they continually need it till they completely clear, which can take sometimes up to 6 months for their acne.
Good. I wanted to ask one more thing. First, I'll ask Dr. Seema the gynae part of it, that this patient is also having hirsutism. Dr. Seema, do you want to put the patient on OC pills or the hormonal pills as Dr. Nozer has told, and then go for the lasers, or what would be your course of action?
Rakhi, I was listening to Dr. Malvika, and I'm agreeing to whatever part she is treating the acne, but I disagree on the part where hormonal contraception and lipid profile things come. As far as my knowledge is there, if patient is of dyslipidemia and she's severely hirsute, she needs treatment, and here we have to treat the cause first, then only we will be able to get this girl, get rid of all those, she will not get it further. So in these cases of dyslipidemia, first and foremost are anti-androgens. We stop giving OC pills, we keep them on anti-estrogens like spironolactone or flutamide.
Yes.
And we are very strict along with that for the contraception, as we were discussing, and other local treatment, whatever she's saying is everything fine. But for me, the foremost importance is treating that hyperandrogenemia, and cause of it is PCOS here. So we just have to outweigh the benefit risk ratio. And today morning only I was going through a literature and I found it, even including, as Dr. Nozer will say, I'm again quoting a guideline, but I was just going through 2 meta-analysis and 1 guideline, and all of them said these girls can be given low dose oral contraceptive pills third generation, along with strict monitoring, first thing, and second thing, vigorous lifestyle monitoring. If vigorous monitoring of lifestyle is there, these girls, they don't show that level of dyslipidemia, worsening of it, be it any kind of metabolic syndrome. So yes,
we've got Dr. Nozer wanting to put a highlight on it.
Yeah, so first of all, let's not make dyslipidemia a complete contraindication for the COC, because we actually know that the estrogen would benefit the HDL levels. Again, when we start off with the patient, and like I said, if you have a woman, a young girl with menstrual issues, cyclical progesterone, or I might even prefer the desogestrel pill instead of what we've talked about. But if there are cosmetic issues, I think she deserves to have an assessment of her androgen levels at the very start. So I would at the least want a free testosterone. I would usually do a DHEAS. I would definitely do a DHT. And in an adolescent girl, I would also do a 17-OHP, because for a very small number of them, you might be dealing with a late onset adrenal hyperplasia. If the free testosterone is elevated, COCs are the first line treatment. You're going to suppress the ovarian source of androgen, and you're also going to push up the SHBG levels and thereby reduce the free testosterone further. If I have a DHT which is extremely elevated, as was brought up by both our dermatology friends earlier, I would maybe not wait for a long time, but I might start off with an anti-androgen right there and then. I must confess here that I have been, while I would favor spironolactone. Remember, drospirenone is very closely related to spironolactone. My preference in these cases is usually to start off with flutamide. Yes, very close monitoring because of your concerns about the liver. Yes, a 3-monthly liver function with a follow-up. I very rarely have seen a problem with the liver, but I will still follow them up. And the initial results are something that you won't get with an OC pill alone. I'm talking about a very elevated level of DHT. 17-OHP and stuff you'll deal with dexamethasone, and that's a different group altogether. Then there is, of course, we haven't even talked about glycometers yet. You're talking about dyslipidemias and stuff. Maybe we'll discuss that. Cosmetologists are our biggest partners and friends. This girl has to start off by looking good. You can't wait for 6 months. Maybe you don't need to start off with lasers at the beginning, but there's a lot a girl can do. A gynecologist has to be her pal and tell her, listen, bleach, wax, thread. Yeah. And once we are done with what we are doing for the next 6 months and your hair growth has thinned a little bit, definitely laser, because that's the way to go. The cosmetologist will also make whatever scarring has happened with her acne a little better. So, it's got to be a lot of things being done. There have to be OCs first line. You may bring in the anti-androgens a few months later or right in the beginning. And it's a very dynamic thing which keeps changing from time to time. But this partnership is very important.
There are few topical applications also, and which type of lasers and topical applications, and how long do you prefer Malvika for all these patients? And because they are adolescent, they want to look good, as Dr. Nozer has told, they always want to look good. So what do you advise, and how long do we take for that?
So first I must clarify that in no way are we against OCPs or any of the other drugs. In fact, we are in support of it, and often almost always, I will tell my patients to visit their gynecologist and get their opinion, because I believe it, like Dr. Nozer said, it's a partnership, and I think they need to be under the supervision of their own gynecologist, and I'm not the only person who should be advising them on hormonal therapy. I like to do it together. The second thing is that I definitely, in a case like her, with both acne and hirsutism, an anti-androgen is almost a must. Now, if she has female pattern hair loss, and she also has hirsutism, my definite choice would be finasteride first, only because it helps both the hair, is weaker in its effect for the skin. Only if the DHT is high, really high, as Dr. Nazir said, will I venture with flutamide, and I can say it works much faster and better, but of late, I've had 1 or 2 cases of hepatotoxicity, and it's really put me on the back foot with using flutamide, which earlier I used really happily. There are even reports to say you can use 125 mg of flutamide once a day and then slowly make it twice a day. They've even come down on the dose of flutamide. But it's a wonderful drug. Finasteride, when there are more, when it's hirsutism and when there's androgenetic alopecia, definitely the choice for me. But if the acne is predominant and the hair issues are less, then aldactone or spironolactone, even 50 mg, especially with cyproterone acetate, is my preferred choice, because it has a broad spectrum of action and starts kicking in by 2 to 6 weeks, and the patients are very happy. The reason I brought this in is because this also has a bearing on laser hair removal. So in this patient, there are going to be 3 scenarios I'd like to share from my experience in my practice. The first scenario is that you counsel the patient, you start treating her acne, she's come to you, you've given her the correct medication, we work hand in hand, and we tell her wait at least 6 weeks, see an improvement in your skin. You can't do laser hair removal when there's so much acne in the same area. So we tell her that you wait for 6 weeks, when things look, your skin looks better, and after about 2 months, if you repeat your test and there's a decrease, that's a good time to start laser hair removal. You can start as early as 6 weeks to 2 months. This is because the hair are thick. They're anyway target hair. You can start it, but you can do gentle sessions and space it out more. Start giving her the cosmetic relief. A girl can't walk around with a beard like that and shaving and waxing. However, if she is already has done many laser sessions before and has had failure to laser because of undetected androgen levels or erratic treatment or non-compliance, then I would definitely defer laser hair removal for 3 to 4 months, treat her acne, get her hormones settle down, bring them to normal, and in the meantime, I would advise eflornithine. Eflornithine is a topical, as you may know, and it is not a hair growth, it's not an epilator. It reduces the hair growth, the rate of hair growth, so that it takes 2 months to work. You're treating her for 3 to 4 months. I defer my laser and I bring in my laser at around 4 months, because by then the hormonal stimulation is gone. What's the last situation? Sharing. The last situation is she says, I just have to get this hair off. I'm getting married. I'm seeing boys. I'm going to work. I don't mind if it takes more sessions. Please do it for me. In that case, good counseling. I will tell her, you have to be prepared instead of 8 to 12 sessions to do at least 4 more. Because the first 4 to 6 sessions are going to be slow. But if her levels are high all over, everything is high, everything is elevated from 17-OHP to DHT to free testosterone, it's a bad idea, because you can actually cause reverse results and the patient gets worse. So, and with active acne to do laser hair removal can aggravate the acne. So you're going to have to find this right balance for your patients, and sometimes it's quite a challenge.
I would like to ask Dr. Sonia ma'am, how often will you reevaluate this patient? What are the benefits of continuing this patient and seeing to it that this patient continues the treatment and there is no breakthrough in between? And because we've already referred our patient to Malvika, she's gone to Malvika, how good it will be to get back the patient to us as a gynecologist? Dr. Sonia.
Malvika said, she's very aptly said that we have to work as a team. You know, basically, hirsutism is one part of it, and we are only concentrating on this particular patient. We may have a patient who may be having regular periods of hirsutism also. That kind of a PCO adolescent is also present. So in that case, then she's Malvika's patient all through. I don't have to do much about it. But if she's continuing to have irregular periods as well, along with the hyperandrogenemia or hyperinsulinemia that she has, then I'm sure she's going to come back to me as well. And if she doesn't, I have to actually check on her and see whether she has achieved what we have asked her to do. One, as Dr. Nazir said, whether she has actually changed her lifestyle and diet to a certain extent. Is she behaving now? Is she not the erratic teenager that she was? One. And second, whether she's taking the hormonal pills that we had advised her. And is she regular with her periods? At least every 3 months she should be getting a period, if not every month. But if she's going to discontinue with the pills, then definitely all the hormonal imbalances that we have talked about are eventually going to come back. And of course, the insulinemia is also going to hit her a little bit. Therefore, it has to be emphasized to her and her family that she has to stick to this and make it a lifestyle habit, make it a lifelong habit, that she will have to go on and off the pill if she's not very good with her exercise and weight maintenance. If she's good with her weight maintenance and her exercise, then my advice to my patients is, look, you don't have to look at the height weight chart. You have to look at your menstrual calendar. As long as your periods are regular, you have achieved your optimum weight. If your periods go haywire again, that means you've gone above the ideal weight which your body assigns to you. If your body is, say, fit at 50 kg, then 50 kg is what you have to achieve. And if you go back to 55 and your periods become irregular, then your body is telling you that something is off again. So that's how we have to tell them, because it's very, very difficult for a child to continue taking all these medicines and try to look beautiful as well. So that is how we have to, keep on going.
I want a final word from Dr. Nozar before we go on to our second case.
Yeah, so the first thing I would do with my patient and her mother is tell them this is a condition. This is something we'll be able to control. Please don't expect a cure, because they think 6 months of treatment and PCOS will be gone. There are no cysts in the ovary. It's a hormonal condition, and we are going to deal with it with lifestyle modification and medication. As Sonia said, I would probably want to see them regularly to keep them motivated and keep them going. I will reassure them. They ask me very often, how long will the therapy continue? And I say, you know what, I don't know, but we will assess you from time to time. Clinical benefits, clinical improvement, I might reconsider taking breaks in the therapy. Otherwise, she's going to continue with this medication till such time when she comes to marriage and maybe when she's planning a family and a first child. If she's on an anti-androgen, I'd like to see them 3 monthly. If she's on a COC, I'd probably ask her to come and see me 6 monthly, but keep in touch with us by emails or whatever else. And you have to be with them for the long term. And I have got, I don't know how many young girls who've been coming to me for years, motivated. They feel so great. They look to you for, for you to kind of congratulate them when they lose weight and they maintain their weight. It's a very satisfying thing to do. A big part of it is, of course, keep the mother relaxed, and she's the one who's more concerned. If you want to take a break, assure them that you can take a break for 2 or 3 months, do an endocrine profile at that particular time, and don't hesitate to put her back onto treatment if required. And finally, I know we might mention insulin and insulin levels. You know what? I've just stopped doing insulin levels because if I have a woman who's got a high BMI or a girl, and if I have a girl with acanthosis nigricans, which tells me I'm dealing with hyperinsulinemia, I'm going to treat her anyway. And all of us know how unreliable and how all over the place insulin levels tend to be.
We'll come back to that.
There's one more important thing which we need to address, that when these girls come to my clinic, they are depressed. We are not looking at mental health. You know, what Nozar is saying is what he's actually doing by calling them up, talking to them, giving them positive reinforcement. He's actually doing psychotherapy, okay? And that is what we all are doing for our patients, okay? But sometimes the girl needs help. So we have to, this is very, very important, because look at her, she's obese, she's got acne, she's got hair, the body image, the self-image, the confidence of that 16 or 17-year-old is at the lowest. So please, I think as doctors, we really need to be worried about, you know, all the time I'm chatting with them. Actually, it's more of a psychotherapy that I'm giving them, because the prescription is one and the same thing eventually. You know, we just write an OC pill, but it's the counseling, the talking, the psychotherapy therapy, which is very important besides, counseling about OC pills also. I feel this is something we need to keep in mind. And PCOS patients, if I want to quote Seema, there was a CREPOS guidelines where all the international associations got together and did a guideline in 2018. It actually, 1/3 of it is on mental health in PCOS. So I think we should also remember that in these patients.
And their sleep pattern. And their sleep pattern. Because majority of these girls have a very bad sleep pattern as well.
Yeah.
That is also causing all these problems and the hormonal imbalance. So if that comes in the lifestyle, but we don't talk about it so often. We are only talking about exercise and food, but we have to talk about the sleep pattern as well.
Definitely. Dr. Nandita has also come up with a very apt, the right thing, because the patients many a times come and tell that I am afraid of my image getting body shamed and all those, the special language, and then they are very justified in telling also. And I think we've justified.
May I just say one thing? I completely agree with Dr. Nandita. In our clinic as well, we don't talk about the complaints first. We first talk about the patient, the lifestyle, diet patterns, eating patterns. We chat with them and we are not judgmental. The most important thing is we want to make them comfortable. We want to make them feel that they haven't come to me just for a package or just for a treatment. They've come because they think we will help them through the journey and process. And often we even construct rough diet plans for them and monitor it. And sometimes my first question to them is, oh, you've lost weight, you're looking great, isn't your skin looking good, how are you feeling? And the mother-daughter scene goes on all the time in our clinics as well. And it is quite difficult to handle. So somewhere we've got to talk, the daughters talk and sometimes the mothers talk. So sometimes I also find that if there's no oligomenorrhea, then glycomet and aldactone, if tolerated well, can be a very good combination to break some of the social barriers in taking OCPs in the milder cases. So this is one combination also which we have found useful. It helps because we know that glycomet also helps in testosterone because they're sensitized to testosterone. So there are softer options also we can discuss with our patients. That's what we do to ameliorate their aesthetic concerns.
I think now my patient is very well treated. Let's move on to our second case. Otherwise, we'll be losing up on that time. I think let's have a second case.
We've crossed. Wow.
We've got 19-year-old 19-year-old girl who has had menarche at 12 years of age, having irregular periods since its onset, and the periods have been every 2 to 3 months only. And her last period was also three months back. For the last 3 years, it's been the same pattern. And the periods used to last for 3 to 4 days and are lighter in flow. There are coarse, dark hair on the face, lower abdomen. She shaves frequently and progressively worsening pustular acne over the face and the back, feeling bloated, fatigued, crampy, irritated and angry and emotional at times. Increased episodes of self-criticism as the self-esteem is low over here for this patient. Family history of obesity and type 2 diabetes in her mother. And her physical examination shows that she was overweight since her childhood. More rapid weight gain was there in the past 5 to 6 years, and BMI is 33, and no evidence of virilization. Tanner staging 5 for breast and the pubic hair. Acanthosis nigricans is seen. There is elevated testosterone. 17-hydroxyprogesterone and DHEA are normal, within the normal range. LH is 20 and FSH is 12. High total cholesterol and elevated fasting 2 hours GTT is seen. So I would like to call Dr. Sebanti ma'am, Sebanti Goswami, to tell us what would be the optimum treatment control for this patient, and how does she want to go about with this patient? How does she want to have the cycle control?
Yeah. So what I would see from the slides is that she's overtly obese, because you said it's 33 or something like that, the BMI. And you have already done the entire testosterone and 17-hydroxyprogesterone, DHEAS and everything. And from that, as we can see, the testosterone is more, but 17-hydroxyprogesterone is within normal limits, 110 you said. So it's well below 200. And the DHEAS is also, you said somewhere around 200 or something. So it's less than the normal value. So these two basically are for ruling out the congenital adrenal hyperplasia and the adrenal source of any androgen mainly. So with that and with dyslipidemia, she again comes back to our square one case of a metabolic syndrome with hyperandrogenism basically. And she has been having the irregular cycle for quite a long time. And the last 3 months, as you say, she has been totally amenorrheic. So our approach to this patient would be, after doing the investigations, which we have done very beautifully already, would be first of all to counsel her about the lifestyle modification, no doubt. And secondly, to have her the first period, and not the first period means not the MENA, she's already had a MENA, to have a withdrawal bleed and to continue with the cyclical treatment. Now the first, whenever this woman, hello, now whenever they come and we start talking about weight loss, they think that they have come for cycle control. And why are we talking about weight loss? It's to enforce that at least 5 to 10% of reduction of weight would also help in improving the cycle. And secondly, about the treatment, she has been amenorrheic for last 3 or 4 months, you said. So we would just give her a withdrawal bleed first. And the best way to give it is with medroxyprogesterone, 10 milligram OD or BT for 5 days or OD for 10 days, whichever you follow. After that, she's going to have her periods. And then we have to put her on.
Dr. Sebanti, we're going to talk about that later on. I would like to, Dr. Seema here to talk on the behavioral pattern and the lifestyle modification, because she's been very jittery on that aspect right now.
Thank you, Rakhi. So look at this girl. She's 19 years old. Her main concern is her BMI is 33. She's already depressed and anxious. So now our whole concern is to make her more confident. And that confidence comes once she regains her whatever body she was having earlier. So here, lifestyle modification, she is clear-cut, as Sebanti said, is a metabolic syndrome along with anxiety and negative body image issues. So bringing up her confidence comes through counseling. If needed, we can take the help of a psychiatrist or a counselor. And in lifestyle modification, this girl is going to break the rule because she's already depressed. So behavioral strategy is first and foremost before we tell what to eat, what not to eat, and taking her into the confidence, explaining her the disease process. That is of foremost important. And then only she is going to follow whatever diet advice you are giving. For the diet, we are not going to, for these young girls, we are not going to give them dal, roti, saag. We are just going to cut her calories. We are going to prescribe a hypocaloric diet, almost 30% deficit. If she's having 13 to 1500 kilocalorie requirement per day, if we just cut 500 to 750, that will suffice. That diet should be balanced diet. As you already said, plate jitna colorful hai, utna acha hai. So that should be all the colors, green leafy vegetables. She has to be told that her carb portion has to be down. She can make things tastier. But just to tell her that don't eat junk, don't ever go in front of all these things, it's not going to happen. So cutting down the calorie is going to work on her if we counsel her properly. And regarding exercise, whatever she likes, it will come very gradually. She has to exercise at least 60 minutes a day at this 33 BMI. Even then, she's going to take 6 months to 1 year to lose. But this should come In a way, we call it smart goal should be there. That should be specific, measurable, timely, and she's interested into it. So she can dance, she can swim, she can play badminton, tennis, anything. Overall, her confidence level, winning that confidence, becoming her partner in crime is more important than becoming her doctor. And that way, she's going to follow probably whatever we are going to tell her.
Very rightly said, Seema, because we need to take care of her as a complete package and not addressing to one
as a symptom. As we all are discussing, she is a beautiful girl. She has to come back to life thriving. We are not treating a PCOS. We are just meeting a lady who is going to bloom if we just handle her properly.
Definitely. Now I would like to go to Dr. Nandita. I want her to highlight on the OCPs because she's been on an irregular cycles for a very long time. So what type of OCPs would you like to give, and how long would you like to give those OCPs?
See, I think in this girl, especially who's young, who is put on a lot of weight, I think the more mineral corticoid type of OC pills will be good. That is, to speak in plain language, drospirenone has a better effect. The weight gain is much lesser. Cyproterone is very, very heavily androgenic. So when we have hirsutism, when we have acne and all those other problems, that can be given. But when there is a weight problem also, I think we can switch to drospirenone. That is one of the ways in which we can treat her. And the other thing I feel personally is with this child is that you have to really, I think it's more mental than anything, all the symptoms that you mentioned. One thing that actually really was glaring was FSH was 12 in this girl.
Yeah.
FSH 12, LH 20. Now, I'm an infertility person, and personally, I would like to do an AMH here. It's very, very important because we do see a lot of PCOS with low ovarian reserve also. So maybe this is the time when we can actually pick up if she is one of those kind of PCOS where the ovarian reserve is affected. And what happens with metformin is, when we add it to low ovarian reserve, the ovarian reserve further decreases, especially when you're trying to get her pregnant. So of course, this is not the situation right now. But this is one message that I want to give everybody, that if you're doing FSH LH and it is elevated in a 19-year-old girl, it should not be 12. So I think we should repeat it. We should do the AMH. I think AMH today has a very important role in diagnosing PCOS, not in the very young, but at least, even the young ones, it's all coming up now. But there's a lot of new data coming out. But in a 19-year-old, it's worth doing her AMH to kind of, in my practice, that's my personal practice, AMH is used to actually classify patients of PCOS. But occasionally we do find PCOS type of patients with low AMH. So I think that really needs to be addressed. And of course, I am a big fan of cyproterone acetate. The weight gain, Nozer, I've seen it, but it's not that much. That's what's my personal thing. But, the girl is exercising, dieting along with it. So it really helps in a way. I think the main also is the face gets cleared. And I think working with Malvika is very, very important because that, that thing needs to be cleared off also. I think it's a complete holistic approach, psychiatrist, cosmetologist, gynecologist, and gynecologist being a friend. I think that's really, really important. Yes, Nozer, and do the AMH.
Yes, we need to do that.
I will freeze her eggs. I will freeze her eggs.
So yes, AMH important. But again, Nandita, and I know that we've got a large number of, firstly, most of these women will have a high AMH. Almost all of them. Very few will have a low AMH. And a lot of women with low AMH will have fertility and conception on their own. So I'll leave the fertility management to you. The greatest thing is we've got so much choice amongst OC pills. So as far as these girls are concerned, basically most of the time second generation out because levonorgestrel tends to be a little more androgenic than the others, except when she is at a higher risk of VTE, of venous thromboembolism. That's when the second generation pill is the safest. Otherwise, I think it's a little dated. If it's a woman like this, the one we are discussing, where primarily you're talking about menstrual issues, again, like I said, I like to play with the different things I have. I find desogestrel works much better with menstrual issues. So I'd like to use the 3rd generation pill. Cyproterone, yes, but that was before I had the option of drospirenone. So for me today, cyproterone is just something that I want to get that initial conquest with, if at all, and then move on to drospirenone. Because of all the different pills, the drospirenone does everything that conventional OC pills was supposed to not do. Less bloating, less headaches, great, approved for PMDD, the least kind of disruption. Menstruation is great. Cosmetic issues are definitely better, and which is why I think I would agree with you on the fact that yes, cyproterone is great, but personally, again, many years of using cyproterone even before we had drospirenone, and now having drospirenone, the concerns that women have with the OC pills, I think the 4th generation pill answers the best. And there again, if you can bring her down to a 20 microgram, that's ideal. But the 15% of patients who might have a breakthrough, I always start with the higher dose, not the other way around. The higher dose gives the woman confidence in the pill. The lower dose you can then move to and always move back to a higher dose if she breaks through. Because if she breaks through with the lower dose first, her confidence in the pill is shattered forever. And then these are young women, and it's great. They are so smart. And you can teach them about extended use of OC pills. You can tell them you don't need to menstruate every month. You can tell them you can menstruate when you want to. And I'll follow up on what Sonia said, even if I'm not using the pill. Suppose there are some women who say, I'm okay, I don't want to use the pill. I will make a kind of a ground rule and say, no more than 2 months amenorrhea. 3 months would be a stretch, because we have to educate these young girls that a lifetime of delayed menstruation and endometrial hyperplasia puts them at risk of endometrial malignancy in the much later life. They are very young, but they have to think about when they are 40. And again, it's the best thing about this is, the fact that it gets you so involved. Every patient is different. Every patient is a challenge. Every patient is interesting. And every time you meet her, you've got something different to talk about.
Rakhi and Nozer, I also add metformin to all these adolescent girls who are obese.
If they are overweight, I don't believe metformin. I know people think PCOS, metformin. Metformin has a role to play, which is why BMI is most important. There has to be a BMI written on the first page of your notes, whether it's a gynecological patient, young girl, elderly lady, pregnant woman, because that's a very, very important marker for her. And if I have a patient significantly higher BMI and I give her a target weight to reach, make it easy, say 24 BMI, but try and get her to a 22. Metformin, the motivation with exercise, you said it so rightly. Every time she comes in and she looks to you for your approval and you say, wow, you lost 1.5 kilos. That's something you achieved. Next time she wants to come back and show off and say, doc, this time I did 2 kilos or this time I did 3 kilos. And which young girl doesn't want to look great and which young girl doesn't want to wear great clothes? And I think we need to build up on that.
Yes. Okay, there's one more question, Rakhi. Sorry, I'm going to ask the question also. Yes. How many of you all have used myoinositol and d-chiroinositol?
I think almost all of us.
Yeah. All of us. We also use it.
I think almost all of us. Unfortunately, there is so much evidence given to us by the people who brief us from pharmaceutical companies. But when you look at guidances and when you look at guidelines and when you look at RCTs, we're not finding that kind of a research. So I think probably something which is not harmful, something which does add to cost, but it's something that's worth, you have very little to lose. So yes, why not? And at least our anecdotal experience from a number of gynecologists in India is that it does seem to make a difference.
Seema, any data?
Yeah, Nandita, same thing is happening with cyproterone acetate and drospirenone. somehow we all are using, and there are only 1 or 2 studies, one Mr. Bhatia and from India, and even in American meta-analysis, they found that these 2 drugs are better, but their population was suffered, 50 to 60% of them suffered from thromboembolism. But we have hardly seen any girls suffering from all these things. Maybe it is genetic predisposition or something. And second,
we are not reporting, Seema. We are not reporting. We are having it, but we are not reporting. We are not reporting. There are not studies to say that, but we are not reporting.
So I did not come across in my small career any thromboembolism, ma'am. But yeah, for other thrombophilias also, we the Indians are less prone. Similarly, maybe something is there, or we are underreporting. And regarding,
Anushka will agree with me, in the infertility segment, we are finding it. We are finding a lot of derangement of blood flows, lot of problems over there, and that is why we are a little wary of this. Although we are the ones, you included, are the ones who are using hormones the maximum. All of us are using it right, left, and center. And we are thankful to PCO that it has brought hormones to India. Otherwise, we were so scared of using OCP. Nozer must have struggled a lot initially, but now with the PCO segment being there, we are much more liberal in our use of hormones. So therefore, yes, the papers have come from Dr. B.N. Chakravarti's unit even on the same issue. So it's not that we are not, but it's underreporting. It's underreporting.
And regarding the evidence for inositol, though it is very weak, but Cochrane has accepted that inositol can be used. Though it has given very low level of evidence because studies were not good, we are the people who are using it the most, and we are not doing anything. We are not reporting. So that,
reporting and evidence base has to be built up because India has got
as an entity, obviously now.
I wanted Sebanti to address the psychological issues of this patient. She had a lot of psychological issues, and should the antidepressants be prescribed for this patient or OCPs? What do we recommend?
Well, why do these patients have psychological issues? You cannot hear me? Hello?
Yeah, we can hear you, Sebanti.
Okay. The question is, why is she having the psychological issue? At the outset, she's having it probably because of her hirsutism or acne or androgenetic alopecia, or because she's obese, or she's having obstructive sleep apnea because of obesity. All are the reasons why these girls are having a psychological issue. So if this is the reason for her psychological issue, then our motto should be ultimately to treat that reason first. Like giving her antidepressants at the first go to a woman who is having psychological issues because of hirsuts all over the face would not be very prudent, first of all. Secondly, if we at all give, first of all, is to motivate her, and if necessary, we can refer her to a psychological counseling along with that. A psychologist friend along with us can also be another second friend to her. Secondly, while prescribing the antidepressants, we should remember that what are the antidepressants we give? We give mostly the SSRIs, no? Serotonin reuptake inhibitors, selective serotonin reuptake inhibitors. Now, these are the drugs which, on the other hand, also cause increase in the prolactin levels and cause hyperprolactinemia. So we would just backfire on ourselves if we start prescribing the antidepressants just randomly, because hyperprolactinemia on top of such a deranged metabolic disease would again add up, and it would burn the issue. It would just set everything on fire. So I would not say that antidepressants should be used first. Rather, we should be trying to treat her hirsutism, acne, alopecia by tackling her hyperandrogenism in the way we were talking about for so long. And then if at all she's having acute psychosis or something like that, which requires the help of a psychologist or a psychiatrist, then we can loop that person in and go for the antidepressants. And lastly, your third question was that, what about the premenstrual dysphoric disorder? Now, PMDD is basically the most acute form of PMS, from which, say, 90 to 95% of women suffer. But PMDD occurs in about 5% or 6% of the patients. And out of the OCPs which we use, the best one which has been approved by FDA for PMDD is the drospirenone one. Because PMDD is basically due to the alterations of the hormones in the cycle, and it is the estrogen component which is responsible for the weight gain and the retention of water and the bloating. So definitely drospirenone is a mineralocorticoid antagonist, so it helps in counteracting the retention of water, etc., which is caused by the estrogen. That is why for the tackling of PMDD, it's a drospirenone combination with an estradiol, which would be recommended for these cases when you were talking about the issue of PMDD.
I would like Dr. Nandita to throw light on these estrogen levels on these patients and what she wants to do.
So, sorry, Rakhi, I was just looking at the questions which were coming. I'm sorry. I've lost track of the discussion.
I was I was asking you is the estrogen level for these patients. What do you want to comment on that?
See, sometimes what I have seen in my practice as an adult, that's when I do estrogen levels. I rarely do estrogen levels in a young girl. But in PCOS patients who try to conceive, a lot of times they are hypoestrogenic. I mean, we're giving them pills and they still don't get periods. So what I do in my practice is give that girl really high dose of estrogen and progesterone cyclically to get them to withdraw. I was just discussing on the chat that I had a patient 15 years ago who did not get any periods. I consulted the endocrinologist, everything, and she was PCOS, nothing else. We did everything possible. And I did PCO drilling on her, that even though she was young, unmarried and all, there was no choice. And she started getting her periods after that. But now I would first try the the high doses of estrogen, try and get their periods if I can, and then put them on a regular OC pill. So this is something that I would do in my practice now. But PCO drilling also is the last choice at the end if you have these kind of patients who are really, really resistant. But do the AMH before. Rakhi, I would do the AMH before I subject any patient to PCO drilling, please.
Nowadays, PCO drilling is the last option, as Dr. Nandita has told very rightly. And I wanted Dr. Sonia ma'am.
Yeah, I just wanted to bring in the ultrasound, which we have not talked about till now.
Yes.
In an adolescent, yes, the ultrasound now is not that important, because if they say if you have the two features of irregular period and if you have hyperandrogenemia, then 2 out of the 3 criteria are met and you have a PCO. So you needn't do an ultrasound if you want to, because basically earlier we were saying the 3 cardinal features must be there to label her as an adolescent PCO. But now let's not talk about guideline. Nozer will be a little upset with me, but joking. But basically the 2, if they are present, yes, then she is a PCO, like we've been discussing all through. But coming back to the ultrasound, what Nandita has just now mentioned about the estrogen levels, if we do an ultrasound, even if it is a rectal ultrasound, she's obese and we can't do a transvaginal, if we do a rectal ultrasound, then if we find a very thin endometrium, it is also indicative of hyperandrogenemia. She doesn't have estrogens, as Nandita has pointed out. So in that case, the ultrasound is a very good tool to tell us what kind of a PCO we are dealing with. Because you will have another subgroup of PCO where the endometrium is very thick. They are the ones who are going to behave like a DUB, where you have hyperestrogenemia along with whatever features of PCO. So that patient will have to be treated a little differently from what we are talking about by giving high doses of estrogen as a withdrawal, where we would definitely only require a progesterone, as Dr. Nozer was pointing out. But in case she has very, very thin endometrium, so I think the role of ultrasound, yes, before we even try to think of doing an AMH.
Yes, Dr. Nozer wants to add in a point.
Yeah. So firstly, in PCO, in a majority of women who are not under treatment, you have hyperestrogenism because of the number of follicles in the ovaries. Yes. And you have hyperandrogenism because of what those ovaries are putting out. I mean, what we are talking about is very, very small subset. And sometimes you have to also consider patients who've been on prolonged treatment, because in that in those cases, there has been suppression of the hypothalamic pituitary ovarian axis over a time. So I completely agree with Sonia, but I also, today's ultrasound machines are great. Today's sonologists and all those of us who do ultrasounds also do it extremely well. And if you can get your information from an abdominal examination, then don't put that 19-year-old through a rectal ultrasound, because it's only a last resort kind of a route if you're not seeing things well. I think today a majority of what we need, we can pick up with a high quality ultrasound machine.
But ultrasound is not recommended for adolescent girls. I mean, I quote a guideline, but because of multicystic ovaries and all. So ultrasound should usually be used for diagnosis in the older age group.
Yeah.
After the teenage.
Not for the young adults.
Not for the very young adolescent. Yeah, but I think 17, 18, 19 is fine.
This girl is 19.
She's 19. And I would like Dr. Seema to throw light on the acanthus nigricans of this patient. She wants to address that issue also.
Exactly, this acanthosis nigricans is just a presentation of underlying metabolic derangements. Acanthosis nigricans as such is not a disease. It is just reflecting how unwell her body is. So in this case, this is because of her deranged GTT, polycystic ovarian syndrome per se, and things. And otherwise, there are few autoimmune and other causes for that. That is a dark area. Now our aim is here, we have to target at two levels. First, to lessen the mark. It should be fading away, so that girl feels confident about her looks. And second, the very reason why is she getting it. And there comes the role of lifestyle along with the metformin, because it's all about metabolic derangement. And once we keep this girl, and looking at her BMI, nothing less than 1.5 grams sustained release is going to work on her. So we have to give her strict lifestyle modifications, metformin, local treatment in terms of retinoids and all the creams. Even I was reading vitamin D analog cream is available. Malvika can tell us more about it. And those applications has to be done along with diet rich in niacin and all these nutrients that is going to help her.
I would like Dr. Malvika to throw light on the deep-seated pustular acne and over the back and then acanthosis nigricans. We've referred the patient to her and what she's got in her basket to treat for this patient of ours.
Sure. Thank you. I've been very quietly listening to all of you and actually learning a lot. So thank you for so much of sharing. I can tell you that this patient is going to land at my doorstep for sure. And it's going to be her acne. Sorry?
I said we've referred it to you.
We cannot do without you.
Thank you. So when she lands at my doorstep, it is a real challenge. This case is a challenge because you're working with somebody who's already unhappy with herself. And I can tell you that the most important thing that's going to make her feel good is when her acne starts clearing. That's the first thing, because she then becomes more presentable. You saw it on her back, you saw it on her face. The second thing is, alongside with it, she wants her hirsutism to go because it makes her socially unacceptable. So I would, and then she's got the acanthosis, and then she's got the depression. So my hands are a bit tied. However, my approach is to create a roadmap. My job is to create a roadmap. I include everybody in it, including myself, which is I like to play a role where my primary job is to keep her, give her a multi-pronged approach that gives her the confidence, where I will treat her acne, I will treat her hirsutism, I will see the drugs she's on, I'll work with them. I would not add too many drugs because of the depression angle. Oral isotretinoin I won't be able to give because of mood swings. I would like to treat her acne quite proactively. I won't be aggressive, but I will definitely make a plan where she will be in the clinic almost every week, because then I can keep a tab on her lifestyle and all her issues that may come up, because compliance is the key. Remember, in a patient who's not feeling good about herself, the dropout in lifestyle, the dropout in sleep, their whole social interaction is so poor that compliance becomes very poor. So she comes in every week and I treat her acne with lights, with photofacials, with gentle treatments, monitor her orals, monitor her topicals. She is going to need 6 to 9 months to clear her acne. So if I give her a roadmap and say, give me 3 months, give me a month, you'll feel much better. By 3 months, your acne is better. By 6 months, the scars will be gone. You will need treatment for at least 9 months to a year. You've got to visit your gynecologist, endocrinologist regularly, and we will start your hirsutism as soon as your acne clears on the face, or we can start it the laser hair removal side by side. And I would, in this case, if the case merits, I mean, there are cases with all shades of gray, as you know, I find that for the acanthosis nigricans, giving her metformin along with myoinositol, very useful. It comes in a combination pill as well. And I find that starting on a lower dose initially till they tolerate it, because even one small setback of a GI disturbance and they're back to square one. They feel, oh, you couldn't work for them. I know that this patient has Dr. Shop to almost everybody around me before coming to me because of her case being so long withstanding. So I've got to grab her in my first consult because I want to help her, because I want to see her through. And it's going to be a process. About the acanthosis nigricans, we have a lot of treatments which, see, girls can't wait for metformin and weight reduction for the acanthosis to go down. It's going to take 6 months, 3 months, 4 months. They need to wear their tees and they need to wear their backless and they need to be out there. So, especially this teen group and the millennial group. So, we use keratolytics, we do retinol peels, we do use keratolytics, we can even use some of our lasers, radio frequency, along with there are some special vitamins which and brighteners, topical brighteners, and alpha lipoic acid, vitamin B6, zinc. These help a lot, along with metformin, myoinositol. You had a question, sorry?
I was about to ask you, what is the age? When do you want to start with the laser treatment and all these for this? At what the youngest age you would like to start?
That's a great question. There is no specific guideline. Again, that has become a pet word here. Guideline, but the general rule is to start 3 years post-menarche. So now, if a girl achieves menarche at 10, then 13 seems a bit early. But if she's already hirsute, you may have to consider, or you really have to investigate her and treat her with anti-androgens, reduce the hair, and you can then tell her to use eflornithine or then do some waxing or threading. But not all girls listen. Some of them by 13, 14 are asking for hair removal, then we'll just do the upper lip. Just the upper lip, and I do enough sessions to get rid of the dark hair so that the lighter hair she can bleach, and I tell them to take a break till she's 16 plus.
Good, great. We've got very many seniors joining in and watching the webinars, and it has been liked by most of the seniors and many audiences are there. And Dr. Pratap Kumar is also there, who's joined.
Very good question.
And we've got many questions coming up also. One question by Dr. Anuradha Ghosh is there. Should we go for whole hormonal workup? And what all hormonal workups need to be done for these young adolescents? And I would like Dr. Nandita to highlight it.
Okay, hi. See, for the young adolescents, I think if my PCOS diagnosis looks good, I would do minimum tests. But as I said, I think all the panelists agree on that the 17-hydroxyprogesterone is important, and doing the testosterone DHT is important. And in my infertile population, I would also do DHEA. So these are the 3 things that I would do if she has acne and hirsutism. Otherwise, if she's just obese and acanthosis nigricans metabolic syndrome, I would not do any of these tests. I think just the I do AMH in all my patients. So just the sonography and the AMH would be enough for me. I wouldn't bother to do all the other tests.
Dr. Sebanti, you want to answer?
Yeah, I would like to say that, as Madam said, that I would not be doing the entire range of the hormones in all cases, definitely. But there are just 3 criteria are to be kept in mind to do the entire, the androgenic range. If there is a very recent onset of severe hirsutism, if the hirsutism is going on in a very fast rate, and if the hirsutism is associated with virilization, those are definitely the cases where you need to do the entire workup of 17-hydroxyprogesterone, DHEA, androstenedione, and whatnot, the entire range. Otherwise, in mild case of hirsutism, like with the Perriman-Calaves score of only say 10, 11, not 12, it's not needed that we do the entire battery of the androgenic tests.
We've got a question over here. Why don't we start with Orlistat 120 milligram TDS along with drospirenone pills in case 2 by Dr. V. Ramanaju from Vizag. I would give.
Why
Yeah.
not?
You can give, that is very safe and recommended, and that too on BMI 33.
But exercise is a very good insulin sensitizer. So that
Yeah,
is why,
but on 33 only exercise might
not do.
I was actually going to ask, what do you all do? Does anybody recommend bariatric surgery at this age?
I do.
Age 90. That's what I'm saying, because her BMI is already 33 at this age. It is actually, she's going into metabolic syndrome. So would we consider that?
Sonia, it's not bariatric surgery. You can put in a balloon and help get it down. Or like my Jindal naturopathy.
What I should be saying is doing something, surgical management rather than a
To
medical.
motivate them. It motivates them further.
Motivates
It's
them.
very difficult to lose weight on their own. They lose motivation.
And all these girls have tried to lose weight and they've bounced back,
Exactly.
bounced back. And 2 kilo weight loss at 33 BMI, and you just binge once and you put on 3 kilos back.
Yeah.
So it's very traumatic. Yeah.
Absolutely.
Yeah, it is.
Good question.
Bariatric surgery
Got
for
a different question over here. Pooled sample of prolactin to be taken, or we need to take a single sample, and does it has a role with OC pills, hypoprolactinemia and OC pills?
Yeah, of course. Prolactin should be done in all these cases. Prolactin and thyroid is the first test that we need to do. Whenever the patient has amenorrhea, that is something that we've learned in basic gynae, which needs to be followed even over here, because the mild forms can actually be because of deranged thyroid or a deranged prolactin. And regarding the 3 samples of prolactin, yes, it's a very good thing, which all the endocrinologists also tell us to do, because prolactin is such a sensitive hormone. It is going to fluctuate all the time. So if you have a pooled sample, it gives you a better measure of the prolactin in the body of the girl.
Yeah.
Both the things, yes.
Raki, because of that, I wanted to just enumerate all the tests we should be doing for polycystic ovarian syndrome diagnosis. May I?
Yes, definitely.
As Madam said, we have to exclude. So for exclusion, we are talking FSH, LH, prolactin, TSH. And after that, the only test which we want to do to diagnose, that is hyperandrogenemia, and that is only total or free testosterone. When that is not raised and the girl is having symptoms not cured, then only comes the role of androstenedione and DHEAS. And second thing, irrespective of the age, all these girls should be having GTT, HbA1c, lipid profile if their BMI is more than 23 in our country and other places more than 25. Just for enumeration's sake, I'm telling that these are important things.
Yeah, again, adding to what Seema is saying, just a point. We have all been talking about the city-bred PCO, but we have to remember that we have PCOS also in the villages and the remote parts of India, where this is just a clinical diagnosis. We are not to do all these tests that we are talking about. Tests are of 2 varieties, one for the irregular periods and second for the hirsutism that she has. So basically, you have to be very selective in what you're doing. If you have a clinical diagnosis, looking at your face, there's really no need to do any such thing over there. You treat her for what she is. That is what should be taught, because basically when you're sitting in a very remote area, you're not going to be able to get the tests right. So don't depend so much on the tests, rather than try to be a better clinician. That is my take on it.
Yes, ma'am. And my acanthosis nigricans, they get cleared on lifestyle and metformin only.
Absolutely.
Good, great. Dr. Pratap Kumar has sent in a word stating that comparison to cyproton acetate, do you think drospirenone is more thrombogenic as it has anti-mineralocorticoid activity is higher over here?
And he's quoted the AICOG.
AICOG 2000.
How can Dr. Pratap be wrong? If he says it is there, it is there. Yes, we are there. But then we do, like Malvika has been telling us, we have to be selective in our choice of the two molecules. One is more effective in the skin problems than the other. So therefore, we have to start with the first one first and then go on to the lesser one. So I think Malvika would be a better person to answer that from the treatment perspective rather than us saying something.
But Rakhi, all the studies that are there are showing that there is not much difference between all this generation. Yeah. So I have not seen in particularly what Sonia was saying. I've got cases who've had a history and then they come for IVF and all that. But I really haven't had history of, women developing thromboembolism because we use OC pills like crazy.
We've seen a doctor's daughter dying of it.
I know.
Yeah, please. So therefore, I'm very wary of it. I'm very.
Yeah, I know. I understand.
It is there, but like I said, we are under-reporting.
Yes. Dr. Nozar, you wanted to say?
Yeah, Rakhi, I missed part of that, but I have to tell you here that I do have a series of patients who have developed thromboembolism with OC pills. And some of these were young adolescent girls who were put on the pill for abnormal uterine bleeding.
Yeah.
And I mean, one or two of them are my patients. A number of patients who've come to me afterwards. The basic problem remains. They've used different kinds of the pill. So I know they say that a 4th generation pill and a 3rd generation pill is higher risk than the 2nd generation, but they've taken all kinds of pills. So when I do start patients a pill, I will also, when I'm talking to them, that if you have any issues with calf tenderness, calf swelling, breathlessness, those are things you've got to report back to us. And for some of these patients, cerebral venous thrombosis, pulmonary thromboembolism, DVT, some of these patients then came out to be APLA positive, not all of them. And management, some of them initially I did with progesterone, though technically progesterone is also contraindicated, but you could use it. And in these patients, I used micronized progesterone. But there was a patient of mine who had cerebral venous thrombosis. We used progesterone. She landed up with pulmonary embolism. What I have used for all these patients, and then I now have a number of them, GnRH analogs.
Yes.
GnRH analogs seem to be safe. I've used it for these girls for their basic problem. GnRH analogs are a very indirect way of dealing with PCOS, but they will deal with PCOS because remember, you're bringing your FSH, LH levels down and you're silencing the ovary. And when you silence the ovary, you silence everything. The effect on the uterus, on the endometrium, and you even bring down the end. One of these girls took it for, most of them would be 6 months, whatever. Then you do imaginative stuff. Some of them have put in a levonorgestrel intrauterine system. Even girls, I had one girl who was 16. She was a law student. We put in an LNG IUCD after having her on a GnRH analog for almost 12 to 15 months. And but be prepared. You have to think about these things to recognize them, because very often a girl calls us, I have a headache, I have a persistent pain, and we just kind of on phone try to reassure them. Please keep in mind that this very rare patient, and of course in all these years, I would probably say they're between 12 and 15. And like I said, many of them have come to me afterwards as to what shall we do. Young engineering student coming with slurred speech because she's had a stroke. Girls like that. And we need to take care of it. But be aware that this is a problem, and considering it's extremely safe. Let's face it. The first thing we have got to tell a girl who's taking the pill and her mother is that this is probably the safest medication in the world, because no medication has been taken by hundreds of millions of healthy people, and we have so much. And obviously, you're going to have a 1, 2, 3 out of 100,000 going to get something like a problem like this. And that does not mean we don't use it, but it also means that when you do use it, please be aware that once in a while you're going to be caught out, and then you be prepared to take care of those girls after that.
But I think, Nozer, what you've added about GnRH analog is something new that I have learned. So thank you.
For me, it was initially the first many girls I used progesterone. It worked well, and then there was this very young. I mean, she's amazing. She's a young girl, Muslim lawyer. Came to me after a cerebral venous thrombosis. Put her onto micronized progesterone. She got admitted with pulmonary embolism, and then we put her onto GnRH after reading a lot. And nowadays, I use GnRH for a number of issues. I mean, women who are bleeding because they are on anticoagulants, because they've got heart valve replacements, women who are at risk of thromboembolism from other reasons, and everything I've read tells me. And now, I mean, I've got so many of them who've done very, very well on this medication.
Can I just say a word? Rather than putting them on long-term GnRH, which has its own problems of osteoporosis in such young women, there's a tremendous bone loss. I would rather induce ovulation. What is the problem in putting them on an oral ovulogel? Putting them on clomiphene or letrozole, and it gets corrected.
One second. Yeah. First of all, these are young girls.
Yes.
They've come to you with severe menorrhagia. I know you could use letrozole, but how long would you keep them on this? And at this point,
because we are on a path,
at this point in time, I want to suppress her estrogen levels. At this point in time, I want to make her hypoestrogenic.
What she's saying is aromatase inhibitor is being used for cancer patients.
You please carry on.
Aromatase inhibitor
on a different tangent only. Suddenly.
It's important.
Yes, it was important. I wanted to know something. There's a question asked. Where has it gone? It was asked that how much amount of the dosage of estrogen we need, to maximum dosage of estrogen what we can give for these patients if we are using it. The patient is amenorrheic for a long time. Dr. Parminder Kaur has asked, Parminder Kaur Sethi, she has asked this question.
Who's taking this? Nandita wants to take
it. You know, in IVF, I generally start with, say, 4 to 8 milligrams per day. Estradiol, Valerate, 2 milligrams per day or like that. That's the dose that I use. I've gone up to even 10 and 12, but I would not recommend that. I think 6 to 8 milligrams per day should be enough for this group of patients. Safe, to be on the safe side.
Yes. 6 to 8 milligram is, I think that should suffice for all of us. And there was another question for Malvika. What is
Hey, Malvika, what is iSchool laser?
So it's a technology. I know. It's good marketing, but it's also a laser which claims that they combine technology and you get faster results and you need fewer sessions. So they are now combining wavelengths to try and minimize the number of sessions. And but you know better than me. If you have a good tool and you know how to master your tool, you don't always have to have these fancy gadgets to try and deliver good results.
Malvika, it's pain. See, I am very sensitive to pain. So that heat from the laser really, it's very traumatic. So that's what I'm asking you. How do you all take care of the pain and all these things? I mean, that is something I think you must be an expert at.
Yeah. Pain is definitely an issue. So one is we do have lasers which have inbuilt cooling. Secondly, you can apply topical lidoprolocane, like topical EMLA. You can apply for at least 20 to 40 minutes and then do the laser. You can do it with extra cooling. You can pre-cool. Your lasers are good chilling. When you post-cool, it helps a lot. Secondly, you have to also do it at a frequency which doesn't overheat the skin. You don't have bulk heating. Yeah. So these are the technicalities that you could do, which you could do. And then, of course, you can go in for newer technology. No doubt about that. But when you ask me about iSchool per se, then what I was trying to say was that there's a constant evolution in laser. There was also one question about hair transplant. we didn't really cover too much about androgenetic alopecia in women. Just for everybody to know, hair transplant works the best in women for the frontal hairline. Okay, it doesn't work so well for when you have thinning on the vertex and crown. However, PRP has made, I'm sure you all know about PRP, and you also use it too. PRP has helped a lot, and we do one session every 3 weeks. We do 3 to 6 turns, and then we do it once every 3 months for maintenance, along, of course, with everything else that we've just discussed. But hair recovery has now become very good. Another new concept is to cyclically rotate the hair vitamins for optimal dosing without overdosing. And we also do the B12, D3, and ferritin in all our patients who have hair loss. And of course, the anti-androgens have a role to play, of which finasteride is probably the best, and there's dutasteride. I don't know if you use dutasteride, but we do use dutasteride, which is a receptor 1 and 2 blocker of it's a blocker, whereas finasteride is only a receptor 2 blocker. So nowadays we're moving more towards dutasteride over finasteride, especially for androgenetic pattern hair loss.
What about stem cells, Malvika?
Yes, so we do stem cells in our clinic. So here you take micrografts from the hairline, and it involves a scalp as well as a hair follicle. So just take about 4 to 8 small punches, and it's done under local anesthesia, and then it's put in a special technology which converts it. It's a grinder that converts it into a fluid, and you inject it like PRP into the scalp. You have to do it only once a year. You don't have to do it repeatedly, and it's great for androgenetic alopecia up to grade 3. That means up to the vertex. And along with your anti-androgens, but they also claim that you can get good results without minoxidil and without anti-androgens. So these are the newer options we have for hair recovery and androgenetic alopecia.
Can we pick your brain? What about just general thinning of hair? I'm sure all the gynecologists want to know. So maybe
everybody wants to know that. So I think if you have general thinning of hair, you should definitely be looking at your B12, D3, ferritin. You should definitely check your thyroid, your prolactin. Depends on your age group, of course. Gynecologists vary from all ages. And I would say that you must have optimal nutrition, not just from your diet, because as we grow older, our needs are more. Repair is less and wear and tear is more. So you need to take cyclical or even 1 pill a day, which has a little of everything. There are lots of new hair vitamins have come out, and you must supplement yourself every day, every year round, not just 2 months or 3 months. I think I have decent hair. I take a vitamin and quite a bit here. I take a vitamin every day for my hair for the last now 2 years. So,
which one?
Yeah, so offline I'll give you all the brands.
I want the closing remarks on the adolescent OCPs by Dr. Nozer sir for these adolescent girls. Closing remarks.
I'm on a webinar.
Mike, sir.
Sorry, yeah. Can you hear me?
Yes, sir.
Yeah, so firstly, it's about PCOS. And the first reassurance this young woman requires is that she is not alone, that we are dealing with an epidemic and that she shouldn't worry. We'll deal with it. We've got lots and lots of solutions for her. The second thing is for the mother, very often her biggest concern is PCOS and will her daughter conceive and be a mother and fertility. And it's important for you to lay this to rest here and now. And what I'll firstly tell them is you don't need to worry about that, because the moment gynecologists start talking about fertility, the mother wants to go and get her 19-year-old married to have a baby as soon as possible. I would normally tell her in a lighter vein that if I had to pick a cause of infertility, I would pick PCOS. So don't worry, we've got lots and lots of treatments, from simple treatments to IVF, which Dr. Nandita can do for her. And she'll be taken care of. When it comes to the treatment, I will tell them that these treatments have been well researched. These treatments have got a lot of evidence behind them, that there is no, okay, the first thing you get asked is what about side effects? And what I'll tell them is there's nothing in the world without side effects. I mean, you drove here in a car, you travel by plane, but all I can tell you is that the side effects of the OC pills are extremely, extremely rare and unlikely. I love that quote which says that OC pills are all safe. There are some women who are dangerous. And I say, your girl is young, she is healthy, she has no medical problems. She's probably the safest person when it comes to oral contraceptive pills. That does not mean that you will not monitor her from time to time. That does not mean that you will not meet her just to see how things are going, how she's responding, reassure her, encourage her, and keep her going. And I think this is probably going to be the most satisfying thing for us, because it is true preventive medicine. I mean, you're preventing so much trouble for her. When she has menorrhagia, after amenorrhea, you're preventing anemia. You are protecting her from malignancies in the long term. You've got the ability of taking care of her chronic issues before they get out of hand. And most importantly, lifestyle changes and making her healthy now will protect her from all the metabolic issues in future. So this is the best time for you to intervene. Adolescent girl coming to you with this problem is absolutely the perfect candidate for you to help and prevent all these problems.
Thank you, Dr. Nozer, for final remarks, and Dr. Nandita, the veto power guest panelist. I wanted you to just give the closing remarks, and then after mine it will close.
I think, Rakhi, you're doing a wonderful job. We really enjoyed, and with all the panelists, especially Malvika giving her bit, and Sebanti there quietly, putting in all the work that she's doing. And of course, Sonia, Seema, thank you so much. And I think it was wonderful. And, the adolescent age group is something that we really should look at, especially in this COVID era, where they're sitting at home and they would want to be treated. So teleconsulting is a must, which all of us gynecologists must do with these patients. Now, they cannot walk into Nozer's clinic and, chat with him. So we'll have to do it on teleconferencing. And I think my only message to everybody is fantastic by Bayer initiative. Thank you for doing that for me last year. Those tools are really wonderful. And believe me, people have told me that they're very, very happy about it. So Deepak, thank you very much. Roshni, who's been working behind the scenes, Vaishnavi, and stay safe.
Thank you, Dr. Nandita, and thank you, Bayer. I had a lovely panelist over here, and the learned panelist. All of you were simply superb, and we over-exceeded the time. Almost we doubled it. And thank you, Science Integra and the Bayer, for bearing with us and helping us out. And it was a lovely panel with all the panelists. Dr. Nandita, Dr. Nozer, sir.
Thank you very much. Our moderator, we enjoyed ourselves. It was an invigorating panel. And I would also like to thank all my co-panelists, making it so enjoyable. And the audience, we hope you enjoyed it as much as we enjoyed doing it together.
Definitely. The audience, and stay
Thank
safe.
you. And for always coming out with out-of-the-box ideas.
Rakhi,
Thank you.
I want to quote the lines of a song by Britney Spears, who says that I'm not a girl, not yet a woman. All I need is time, a moment that is mine to find the place between. That's why they are so special.
Lovely.
How well said. Lovely.
Superb.
Thank you, everybody. And it was a wonderful session for me too.
And
And my partners in crime.
Meenal, thank you.
Thank you.